So welcome to EAUTV. We are here in Paris, the first day of the 24 meeting. We had a very nice plenary on stones this morning, and I'm quite happy. I'm Thomas Knoll from Sindelfingen, Germany, that I have here Yong Cho from Korea, South Korea, and Eugenio Ventimiglia from Italy. Both very well-known experts on stone disease, and this will be the topic of this EAU-TV session. So Yong, we just spoke about your long trip to Paris. What do you think about the meeting this year? What excites you most?
Basically, whenever I just visit EAU, actually, I always enjoy very many contents about stone. Actually, just I am a stone and BPH guy, so there are so many attractive contents here in EAU, so I'm enjoying a lot. So basically, I always follow the topics and sessions about stone and BPH, and every day is so busy with that.
It's a long days. And how about you?
It's quite tough to keep up with the schedule, but at the end of the day, I believe it's so much novelty to get through. And meeting colleagues from all over Europe also gives something which is an added value to the whole experience.
Create scientific content, but it's as well networking. And meet people, get new ideas, friendship, of course. So in terms of stones, in this session this morning, we touched several topics, and we will have abstract sessions. We will have thematic live surgery, semi-live surgery in the next days. If you start, Yong, what do you believe is the major trend in interventional stone surgery right now? What is going on?
Basically, for stone surgery, endoscopic stone surgery, we are using very many devices at once together, simultaneously, from the endoscope to the flexible URS, because we are using extra-sheath guide wires, so many devices we are using. But the point is the combination of these devices can make, and we have to check whether these combination of many devices can make a significant difference and just increase in surgical efficiency and safety issue as well. So basically for stone surgery, when I change one of them, I feel a little challenging situation because the combination actually just changed. So, and basically the many technologies are trying to make many new devices regarding stone surgery devices. So we need to find the best combination for improving our surgery efficiency and safeties. But basically recently the main topics about suction, and I feel the robotic technology, because robotic technology is a platform technology, and they can merge many other technology and many other devices into this platform. So I feel there are so many things to study about robot technology.
Please.
And I guess you raised a very good point here, because to me, we have a very quickly arriving new technologies. At the same time, we sometimes lack the evidence supporting these technologies, because the improvement is so fast. And also when discussing these topics with our patients, it becomes challenging a little bit to advise them regarding what could be the best options regarding also new technologies. What do you think about it?
Basically, even though we have the devices, but actually we have to consider, for example, in terms of the suction, we have to consider whether this suction works in one path or one way, two paths, I feel, for example. So if there are two paths, we can just we can irrigate through the one path, and through the other path, we can do suction. So, but with a single path, with suction, actually, we have to do both irrigation and suction together. So actually, even though we can have the same concept and same the devices, we have to think of the way of working to just increase the stone efficiency, surgery efficiency. So basically, we have to test every step with the same devices. So actually, it is a quite complicated process. But just I feel it's very just interesting to me.
I mean, what we touched was, well, very, I would say, simple technology like the guide wire and very complex technology like the robotic platform.
Yeah.
So again, do you have experience with robotic uteroscopy? And if so, or if not, what is your opinion on this? What do you expect from this development? Is this, well, the game changer as it had been for oncological surgery, or is it just another gadget that costs a lot of money?
I have to disclose I have very little experience. I tried one of the European robots. I have to say we are at the beginning of the era, I guess. And everybody doesn't want to look like the old-fashioned open surgeon that when robotic platform arrived for oncology, they said, come on, this is never going to take over. And in the end, indeed. So we are struggling in between to find the best alternative or platform. We are still in an embryonal phase, I would believe. But thanks to all the efforts also coming from Asia and Korea, sooner or later we will have some little step, some little game changer step. And like you said before, I think your concept is really intriguing. I mean, the platform has to be meant not something that will replace urologists, but something that will make it easier to integrate all different technological steps coming through.
Yeah, I totally agree, because robotic technology should not be the substitute for surgeons' skill and surgeons' experience. I think they have to support us to in improving our surgical efficiency. So, but just as you told me, that it is a matter of balance between the cost and cost effectiveness and the technology. So we need to find our best way, best conclusion, actually.
We had today one debate discussion on the gray zone in the guidelines, so the medium-sized stones. And since some years, there is, well, driven by technology, there is a tendency to do more and more bigger stones with retrograde approaches, in contrast to PCNL. You touched several technological developments like the suction. We did not talk about lasers yet, the robot. And I know you're a PCNL guy as well. And do you believe this technology will change the concept, especially in this region where right now, by following the guidelines, we can offer virtually everything? And what is your opinion on that?
Yeah, very good point, because many urologists feel PCNL still is a little bit dangerous. Of course, the complication rate is decreasing, but I cannot guarantee the PCNL is 100% safe procedure on our daily practice. So still I am using some coagulation device for just bleeding site in the percutaneous tract, and maybe it'll be published soon. And actually, we are trying miniaturized devices, more and more miniaturized devices. And many people are interested in ECIRS because we can reduce the number of percutaneous tract. Because all of these facts or this information means that we are worrying about, of course it is minimal, but the complication of PCNL tract. So recent technology, I feel it can show our bright future about the expanding role of flexible ureteroscopy to treat bigger and bigger stones. Actually, just regarding the flexible ureteroscopic surgery, actually we worried most about complications like pyelonephritis or urinary tract infection. But with suction technique, we can reduce the intrarenal pressure, or we can control the temperature very efficiently. And with robotic platform technology, we can provide the best protocol for stone fragmentation to control the intrarenal pressure and temperature very safely. So maybe we are moving to expanding role of flexible ureteroscopy to treat bigger stones. So I think it's very promising, but we need some time and money to get the final conclusion.
I mean, safety is certainly a concern. And you gave a nice talk this morning about shared decision making. And during the later discussion this morning, someone said, I like shared decision making if the patient has the same opinion as I have. So, I mean, that is probably not what we expect from this term.
No.
So how do you, if you see a patient in your office with, let's say, a simple 1.5 centimeter pelvic stone, healthy patient, no comorbidities, how do you counsel the patient? What do you tell the patient about risks, safeties, follow-up?
So it's very complex in this situation to implement truly shared decision making, because you have the ideal case, and in your mind it has to be treated according to what you perform the best, but also to what you like the most. Because I mean, we have procedures that we do like better than others, of course. At the end of the day,
If you say we, you mean us, or do you mean the patient?
of course. The thing is, you need to take your time, because it is time consuming to discuss with your patients all the possible options. And it's not just about making the list of all the options.
Yeah.
The patient, of course, has to be informed about what are the possible consequences in terms of effectiveness and safety of your procedures. And the final decision has to be taken together with the patient. I have to say that it is becoming more and more common of patients coming at my office telling, I want to do the procedure with the laser just because they read that is the laser.
Is a laser, right?
Something like that. Or I don't want PCNL because my neighbor had PCNL, it's been bleeding a lot, or the other way around. I don't want uroloscopy because a friend of mine had it and he spent 2 weeks doing antibiotics at the hospital. So patients are more and more informed. They look for second, third opinions. And to me, if you first if you need to do the best for the patient, also if you don't want to lose the patient or to have the patient to go see the urologist next door, you have to inform him or her in the most appropriate way. And you need to invest time. And like we were discussing this morning, if you're very busy, if you work in an academic setting, the published data show that you are not really keen on doing it, not because you're a bad guy, but of course because you don't have time in your practice. So we need also to discuss with administrations at the hospital, asking for more time during consultations, explaining them it's needed in the end.
So, I mean, information is an important issue. In your countries, are there any platforms where the patient may inform him or herself, or do you refer to the patient information from the EAU? What do you recommend?
We are struggling to have patient information leaflets for surgery and before surgery. Italy is not a huge country, but still it's quite a composite country. So, for instance, people coming from southern Italy, they will still see the doctor as a god, for instance, some of them, and we rely on them totally regarding their choice. Perhaps people coming from German-speaking Italy from the German-speaking part of Italy will have a completely different mindset.
Yeah. Okay.
We try to do our best, since the time during consultation is not always enough, having written material in order to inform them. But we also we try to engage patients' associations, which are becoming more and more important in our practice. We are trying to understand what's best, and also the idea that patients value a lot the thing that they prefer something which is effective but also minimally invasive has to be weighted according to their clinical scenario. So it's not an easy task. We have very little data in the literature to rely on. And I guess this is very dependent on the cultural background of the patient you have in front of you, of course. I don't know, in Korea, I guess the cultural background is totally different from my country.
Right.
At least this is what I guess.
I don't agree. Italia is a small country. I don't agree. So I think, but just maybe it's quite notorious because Korean doctors are consulting our patients very short time. So usually 30 minutes with a single patient. But actually all the patients across the globe want to know more about the treatment. So I think the shared decision making is very important topic. So, but just everybody knows that Korean doctors are meeting the patients very short time. But actually, we try to give more information to our patient with some videos or some video information. And actually, each hospital is trying to make their own contents with this video type education materials. But actually, we felt some limitation because different hospitals are making different contents.
Correct.
And so recently I saw the video in the YouTube made by EAU about ECIRS, for example. So maybe from since 2 weeks ago that I am introducing the video of EAU about ECIRS to my patients in the
It's amazing
clinic.
what they produce, and they have millions hits sometimes. And I like this very much. So because if you leave the patient with Dr. Google, they will read a lot, and they won't get a real reliable information. Let me just ask a little provocative. I mean, we are talking about involving the patient. We are talking about shared decision making. My experience, not only with stones, with prostate cancer, is comparable. Is only a very little percentage of the patients want that they make the decision by themselves, with our support maybe. And at the end, they always ask you, what do you recommend? Maybe only in Germany, not in Italy and South Korea. But if we go back to stones and the medium-sized stones and the gray zone in the guidelines, if I tell the patient you can do shockwave, uteroscopy, and PCNL, and I explain advantages and disadvantages, at the end they ask usually, what would you do yourself?
Right.
And I think that is a little the danger maybe, because then we are biased. So I love more doing a PCNL because it's quicker than 2 hours uteroscopy. Others do different. So so how do you deal with this? Is this different in your countries or?
No. Have you ever heard about doctor shopping?
Doctor shopping?
Yeah, Korean patients are visiting so many hospitals to ask the same questions to doctors. So they visit one hospital and the other and another. That's what we call this doctor shopping. So finally, because you are working for the referral center, right? That's why the patients ask, what is your opinion? So I am the same situation. So basically, but the best answer for physicians like us is, the patients can say, I'll follow your recommendation and your thought. But actually just in Korea, actually, doctor shopping, and just we have to explain the reasons why we choose this treatment to our patients. But actually, fortunately, recently, many patients are asking, I follow your opinion. But actually, basically, surgeon's skill or experience, different experience according to each different treatment actually should be considered also.
I think that is a major issue because, I mean, if we always just refer to papers where super experts in something did a specific procedure, to assume that in our hospital the results are the same is not correct.
Totally agree.
So if in a hospital you said some doctors are afraid of puncturing the kidney, if it's like this and if the experience with PCNL is low in a specific hospital, it's certainly better to recommend uteroscopy. I think that is something we should keep in mind. But of course, it requires some honesty, not to lose the patient to a different hospital where the experience is better.
Definitely. And also, it's the same thing when I call a plumber or I consult a plumber at home. He may be discussing with me different type of pipes, but I mean, it's up to him to make the final decision.
Correct.
And it may be maybe that's similar also for us, but I totally agree with your point.
Actually, that's why I try to prepare all kinds of treatment. I become familiar with all this treatment because I want to be neutral for patients' benefit.
And do you believe you are neutral or?
I try to.
That's at least it's the aim, right? So we spoke a lot about intervention. Let's talk a bit about metabolics, stone analysis. I must say, I realized today for the first time in the plenary that there's a difference in recommendations in the EAU and the AUA guidelines. I was not aware of this, because for me it was always clear that, after the intervention, we need to do stone analysis because this is the base for everything. And Manoj Monga said, well, in most cases, this is not the case.
Yeah.
So what is your opinion on this? How do you do it in your daily practice?
I was actually puzzled too by the US point of view regarding that point. At the same time, it is very pragmatical.
Yeah.
Because I guess that if we as urologists are able to manage most of the patients, it means that since we are not nephrologists, so perhaps we're not properly trained in the field, perhaps in most of the cases, it's not really needed 100%. The thing to me is that it's not easy to get it understood in the beginning, first. And second, if we look, at the data, 50% of the patients with stone disease will have a second episode, at least in the next 5 to 10 years. And when this happens, the patient comes to you and you tell him, did you have your first stone analyzed? And the patient says, no, should I have it done? It's always an uncomfortable situation to me, because it seems to the patient that he's been losing that time, or that he could have prevented that second event. So I totally understand the US point of view. It's very pragmatical, but since my healthcare system allows me to do it, it's not much of a challenging task. I have wonderful nephrologists working together with me. I think it would be a pity not to do it. And also at the same time, it's true that not all patients are compliant. 24-hour urine test, it's not that complex, but also not that feasible, at least not always. And at the same time, all the type of lifestyle, dietary modifications that patients have to undergo, they're quite challenging as well. So I think it's an effort that it's worth doing, although patient compliance, it's not always exceptional, but that should not be an excuse not to do it. At least this is what would be the Asian point of view?
Basically, Dr. Manoj Monga told us, right, the stone analysis would not be so necessary, but actually the patients want to ask what my stone is, actually, what components. So actually, normally I do the stone analysis, but I normally check the two different stones for different stone analysis, because they can show some difference in many cases. So actually, of course, I agree that a single stone analysis would not be sufficient to understand the stone, what the stone components are. But actually, I do the twice. And then just 24-hour metabolic evaluation is very important, because when I recognized it, because the general surgeon who was interested in parathyroid gland, actually. So the occurrence rate, especially in Korea, is very low when he compared with other countries. So he requested me, okay, just please check metabolic and please refer to patients with some problem with in the parathyroid glands and blah, blah. So that's why I just actively started to screen the metabolic evaluation for my stone patients. And I just referred many patients to him. And basically we can find some, for example, if there are some remnant stones after surgery, but we know the nephrocalcinosis and distal type 1 renal tubular acidosis, actually the stones occur usually in distal tubule. Actually, we cannot see the stones, the renal collecting system. Actually, how can we explain to our patients about this remnant stones? But we couldn't see any remnant stone inside the catheter system, but there are some. When I check the CT scan, we have to explain some more information to our patients. We have to check, right? And we have to explain this kind of thing to our patients. But if we don't check any metabolic things and CT scans, or actually, we cannot explain anything to our patients.
No, and I would just add, what I realize is, since we completely switched, I think in all countries, from conventional imaging to CT imaging, we lose some information that we were used to in conventional imaging, like the radiolucent stone. And in the past, we thought about, it might be uric acid. We may do chemolitholysis. Today, nobody cares. Nobody
Yeah.
routinely measures the density.
Yeah.
So, I think it's quite important to keep this in mind, that it's not just the surgery, it's as well metabolics and stone analysis.
Yeah, patients may complain, how could you relieve some stones in my kidney, right? They can complain.
So there's a lot to be done.
Definitely.
Thank you very much
Thank you.
for joining. Thank you for joining EAUTV, and I hope everybody has an ongoing, exciting meeting. Thank you very much.
Thank you.
Yeah.